Okay, so we're going to start with the basics, and we're going to work our way up to, at the end of this, where your highest priority is going to lie when we talk about the concept of diabetes emergencies. This is a multidisciplinary topic, and probably one of the most controversial of the presentations that I talk about, simply because in this presentation, which ultimately is about our diabetes emergencies, hyperglycemic emergencies and hypoglycemic emergencies, there is an increasing need to really unpack the beast that's at the centre of these emergencies, and that is the concept of diabetes. So forgive me if I'm pitching this at a very, very low level to start with, but what I want to do is take you on a little physiological, pathophysiological journey with me. I want you to consider what you currently know about diabetes, how you would define diabetes, and how you would understand the normal ranges for blood glucose levels. Can we start first with diabetes? What is it? This is a little bit interactive. And it becomes more interactive when I do that awkward pause at the end of the sentence, and then you fill that space of silence with noise, yeah? So let's try that again. What's your understanding of diabetes? There's no wrong answers here. Abnormal glucose? No or not enough insulin being produced? Resistance to the insulin that I have produced or that I've exogenously given myself, because we see insulin resistance in patients who give themselves insulin as well. Yep. Anyone else want to add to the mix? What is diabetes? Say again, sorry? It's a mongrel of a thing to have. That's absolutely right. Yep. A metabolic disorder. Excellent. I've always said we're always one Tim Tam away from diabetes. So yeah, maybe that transpires to one too many cocktails in Thailand away from diabetes as well. Okay. Now, you've heard your colleagues speak of what their expectation or what their understanding of diabetes is. Does anyone want to add to that? Does anyone else want to give me their take on what diabetes is? Sugar sitting in the wrong place. Okay. Diabetes is none of those things. Diabetes is simply a term that we've used in medicine for hundreds of years to describe passing too much urine. That's what diabetes is. And there was a time in history when a person would present to their physician passing too much urine, or their child was passing more urine than what had been expected. And part of the assessment of that person who passed too much urine was that the physician would taste the urine. Primitive urine testing. Remember, this predates the dipstick. And when the physician were to taste the urine and it tasted sweet like honey, the Latin word mellitus or mellitus, which means honey, was used to describe the increase in urine production that tasted like honey. In other words, sweet urine was called diabetes mellitus. If I, as the physician, were to then taste the urine and it had no flavour at all, it was insipid, then the Latin diabetes insipidus would be used. The term diabetes has nothing to do with sugar, it's everything to do with urine. Can we just start there? Now we're going to go to diabetes mellitus, which is everything to do with urine which tastes sweet. Diabetes mellitus. It should therefore stand to reason that a person who presented with what at one point in time, or what we currently would call a hypoglycemic episode, this was not something that was necessarily understood until we first had a reference point of what would be considered to be a normal blood glucose level, and that came much later than presentations of people with diabetes mellitus because they would pass large amounts of urine. What do we call that? What's our Latin term for passing too much urine? Polyuria. So a person would present polyuric, and this is how we first started to understand the concept of diabetes. And if that polyuria was sweet to taste, it was referred to as polyuria mellitus or diabetes mellitus. And this is where we have diabetes. But if you were to present with a hypo that is incredibly rare outside of the administration of exogenous insulin, it's very rare to have a hypoglycemic event. If you presented with a hypoglycemic event, we never recognised it historically. We didn't recognise that because we didn't know to measure your blood sugar. So your unconsciousness, unfortunately, would lead to a loss of airway control, and you would die. Low blood sugar level kills in minutes. But high blood sugar level lasts for days, weeks, months, often before it's even recognised. So diabetes emergencies in the hyperglycemic stream tends to be a delayed presentation. Nobody has a normal blood sugar level this morning and then they're in DKA this afternoon. And if they do, there is something seriously going on with their pancreas suddenly stopping the production of insulin. Yeah? So, when we come back to the concept of this disease state that we call diabetes, later on in medicine we came to the realisation that diabetes mellitus had a diagnostic criteria that was certainly based on polyuria. There are other polys that are involved in the recognition of diabetes. What are those other two polys? Polydipsia, so very, very thirsty, probably because they're peeing so much they need to, and polyphagia, something that we all experienced just now outside the room. So polyphagia, polydipsia, polyuria, the three polys of diabetes, the recognition then and now is that if those presentations initially were to come into a GP service or into an emergency service of some description, then it would be fair and reasonable that not only would we look at their urine, but we're also going to look at their blood glucose. And when we see their blood glucose, what we will inevitably find with those three polys present is that they're going to have an elevated blood glucose level. So here we are, we've come to a place where we're now looking at BGL. So what's normal? What were you taught? What's a normal blood sugar level? Without any qualification of that question, what's normal? Shout it out, because you're almost certainly going to be right, 4 to 8, if you say the numbers that are in your head. What is the normal blood sugar level? Tell me. 4 to 8. No, that's wrong. Where did you hear that? What's a normal blood sugar level? You were taught 4 to 8. Is this correct? You were taught 4 to 8 because you were being taught about diabetes, and people with diabetes have to stay within a range that's considered to be safe. And that range is, say it again, 4 to 8. But that's not a normal blood sugar level. A normal blood sugar level, we now currently understand, is 3 to 5.5. I'm going to say that again because you don't think you heard me right. 3 to 5.5 is a normal blood sugar level. Now, we have to make sure that we're measuring that blood in a fasted individual, because it would be fair and reasonable that if I'd sunk my body weight in Tim Tams 10 minutes before you took my blood sugar level, there would be a challenge to the 5.5 ceiling. Would that be fair and reasonable? Good. So, we have a situation, therefore, where a person who is fasting and has no diabetes, no diagnosis of diabetes, there's an expectation that we will see a blood sugar level that hovers in a fasted state between 3 and 5.5. Anything above 5.5, that 5.5 up to 6.5, we would have to suggest this is somebody that needs to have further testing. That is an impaired fasting glucose state, an IFG. Anything over that 6.5 mark, in a state of fast, we would have to suggest we're going to need some more assessment of their blood sugar level over time to make a determination as to whether they're always in a state of elevation, in a state of fast. And we would often use things like HbA1c assessments to look at a more long-term blood glucose control, or alternatively, in some we might choose a glucose tolerance testing, oral glucose tolerance test, something along those lines. But ultimately, the normal values that you were taught were normal values for somebody with diabetes. They weren't normal values for the rest of us. So for the rest of us that don't have diabetes, you're not expecting somebody's blood sugar level to be over 5.5 in a state of fast. So what if they've eaten? There are paramedics and nurses and doctors in this room that are going to take random blood sugar levels. We can't wait on presentation for them to go through 6 hours of fasting or 8 hours of fasting to get a fasting value. We're going to take a random, right now, blood sugar level on a patient who comes into our care, particularly if they're unwell. And we have to have a number that we're comfortable with. And this is where our 3 to 7.8 comes into play. Can you see that's really close to what you were taught as 4 to 8? So the 3 to 7.8, a ceiling blood sugar level for somebody postprandially after food, 7.8. Anything greater than that 7.8, you would seriously question that person's ability to have a glucose challenge. And therefore, we would probably see that they're sitting in a state of pre-diabetes, whatever that's supposed to mean. But there would be an impaired glucose tolerance in those patients, an IGT. Okay. So with the absolute ceiling of a blood glucose level being 7.8 in a person who doesn't have a diabetes diagnosis, diabetes mellitus diagnosis, with an absolute ceiling of 7.8 straight after they've eaten, and an absolute bottom number of 3, can you see that we've got a 3 to 7.8 range that we've got to play with as clinicians, expecting that our patient, if they're sitting in that range, we don't need to be worried that they're having either a hyperglycemic or a hypoglycemic emergency. Would that be a fair kind of goalpost to work with? Yes? Beautiful. Now we can get started. I became acutely aware when I was writing this session that I teach a lot of physiology, and there needed to be a bit of physiology before we just flew straight into the emergency. So I'm more than happy to take questions around this stuff as we go through. And I believe we've got a little bit of time for questions today, which is nice. So hyperglycemia, ultimately an increase in blood glucose level. You would consider somebody to be hyperglycemic at in any time of day or night when their blood sugar level was above 7.8. And you would consider that they were hypoglycemic at any tick of the clock when their blood sugar level was below 3. Now, no one in this room is comfortable with 3. Personally, I'm not comfortable with 3. I want everyone above 4. But 3 is where it's at, and most of the time, you and I, when we go to sleep at night and we're in a state of fast, our blood sugar level drops down around there, and we're sound asleep with blood glucose levels hovering around 3, and that's not causing any harm to us. There's no reason why it would be causing harm to any other patient. Don't get too stressed when somebody has a blood sugar level that's sitting at 3.1, 3.2, somewhere down around the 3 mark. But we are concerned when it dips under 3 and the patient is symptomatic. We're concerned when it's under 3, below a normal range, and the patient's symptomatic. In the same way that nobody in this room is worried when my heart rate is sitting at 48 if I'm asymptomatic and I'm an elite athlete. But if it was sitting at 48 and I'm not asymptomatic, I'm pale and I'm cool and I'm clammy and my blood pressure's in my boots and I'm drowsy and my heart rate was sitting at 48, you would say, yes, this is a bradycardic number. It's something that I should be concerned about. Symptoms plus a value that's abnormal equals a crisis, yes? So merely having a blood sugar level that's sitting at 3 or 2.9, if we had to cross some line, is not necessarily a call for action unless the patient is demonstrating some signs and symptoms of change. That said, I totally take on board that I'm an incredibly uncomfortable clinician once somebody's blood sugar level starts to get down around that 3 number, and I would almost suggest that everyone with a blood sugar level down around that 3 number would be experiencing some signs and symptoms of a hypoglycemic event, and therefore that would absolutely be a trigger point for me to want to intervene. Would you concur with that? Does that seem fair and reasonable? Okay. So, you've possibly seen, and I've broken the number one rule of PowerPoint presentations in a conference, and that is I've put more than 6 pieces of information on the slide, and my font size is smaller than 32. So I apologise about this, but it's a cut and paste straight from Diabetes Australia. These are the target ranges for somebody with type 2 and type 1 diabetes. Type 1 diabetes, for those at the back in the cheap seats that can't see, type 1 diabetes, 4 to 8 is the target range for somebody that you're treating, managing, supporting with type 1 diabetes, according to Diabetes Australia. And target values before meals 6 to 8 for type 2 diabetes. 6 to 8 for type 2 diabetes is considered to be a normal range for somebody with type 2 diabetes. This is straight from the Diabetes Australia webpage. Now, postprandially, 6 to 10 is considered to be acceptable. If you or I had a blood sugar level of 6 to 10 without a diagnosis of type 1 or 2 diabetes, you would say that that was hyperglycemic and you'd be possibly sending me away for an HbA1c. Would that be fair? Because that's absolutely what we should be doing. We should not be tolerating somebody without a diagnosis that has a postprandial or a random blood sugar level of above 7.8. So that 6 to 10 target range for type 2 diabetes is for diabetics that are in that type 2 phase. A term that I hate. I think we need to get rid of the term type 2 diabetes and call it for what it is, insulin resistant syndrome. So our assessment of the patient is almost always going to involve the life threats, airway, breathing, circulation, and level of consciousness, where level of consciousness is often one of the first things that we're going to see will start to change with any extremes of blood sugar level. Either high or low, we're going to see an alteration in consciousness, much, much quicker in the hypo patient. Obtaining a baseline blood sugar level is obviously going to be very much a big part of what we do, but if you had an unconscious patient and no capacity to be able to determine blood sugar level, I would hope that you would err on the side of caution and give glucose anyway. Remember, glucose never killed anyone, but a lack of glucose does quickly. So if my patient was unconscious, in coma, with hyperglycemia, some exorbitantly high blood glucose level, who's done a BGL on a finger stick and it's just come back HI, right? We don't even know what that number is. It's just too big for the machine to tell us. And it would be fair and reasonable to say, well, it's inappropriate to give someone who we know was hyperglycemic some glucose. But remember, we're talking about a patient who's unconscious and we don't have the capacity to be able to measure their blood sugar level if the last person to use the BGL machine left it somewhere in the ward that we couldn't find it. Or there was no battery, or they took the last bloody stick out of the little thing and never restocked the machine. I know that would never happen in the real world. Err on the side of caution and give the glucose. The glucose that you gave to a hyperglycemic won't cause harm. But the glucose you don't give to somebody who's unconscious because of hypoglycemia may actually sign their death warrant. And it becomes therefore an important intervention to bring blood glucose level up if we didn't know what we were dealing with. If we do know what we're dealing with, then of course we can treat appropriately. So let's take the patient with a hypoglycemia. We know that their blood sugar levels come back at 1.1. Is anyone worried about 1.1? And my patient's unconscious. That would be a fair enough reason to say there could be 1,000 reasons for an altered level of consciousness, but at least let's get that blood glucose back to a normal range to see if we can exclude hypoglycemia as the antecedent for that altered consciousness. It would be fair and reasonable to bring blood glucose level up. Now, in a patient with a hypoglycemic episode, we obviously need to bring BGL up, and there's 2 ways we can do that. We can give them something to eat, or if that's unsafe because of their level of consciousness, we would have to go down a parenteral route. and give something like glucagon or something like glucose to be able to bring that blood sugar level up. Depending on what your institutional protocols are going to suggest, you'll use one of those pathways. Please don't take somebody who's unconscious and shove a sandwich down their throat. Please don't do that. That's an incident report you do not want to have to fill out. Glucogels are okay for people who can swallow, but if they're altered in their level of consciousness and their gag is not safe, you can see that giving anything orally to that patient potentially is going to cause harm. Okay. So the hypo, somebody with a blood sugar level, traditionally it's below 3.6 in all populations, but we would suggest below 3 in somebody that did not have diabetes. A hypoglycemic episode may be as a result of an overdosage of insulin or a disparity between the amount of insulin that's been given against the time that the person has taken some sort of carbohydrate meal. So a person can have a hypoglycemic episode when they take their normal amount of insulin today, but they don't eat in enough time for that insulin to have some sugar to play with, essentially. We see type 1 diabetes, people who have type 1 diabetes and therefore are dependent on insulin. We see them having hypoglycemic episodes far more often than any of the type 2 diabetics. Up to 10 or 15 years ago, type 2 diabetes, many type 2 diabetics were treated with medications that were literally oral hypoglycemics. We tend not to use oral hypoglycemics for type 2 diabetics anymore. We use medications that target the problem, not the symptom. The symptom's high blood sugar level with type 2 diabetes. Instead of telling their pancreas to work harder and make more insulin, they were the glipizide, gabenclamide, glycoside, remember all the sulfonylureic drugs that we used in the 70s and the 80s and the 90s that are now absolutely not indicated in type 2 diabetes. We've moved into our adult pants now, and we're giving patients medications that target insulin resistance rather than insulin secretion. But in those older patients with type 2 diabetes that take the drugs that start with G, we tended to see sometimes a drop in blood sugar level because that's deliberately how these medications would work. They would stimulate the pancreas to make more insulin. Now you had a disparity between the amount of insulin and the amount of carbohydrate intake that they were playing with. They essentially were giving themselves some insulin by taking these oral hypoglycemic drugs and then being in a state of fast. Who has been in that environment where they've seen their type 2 diabetic patients on glipizide, gabenclamide or glycoside drop their blood sugar level like a stone when they were fasting preoperatively? That's a classic example. Yeah, they took the medication, yet because they were in fast, that increase in glucose that they would expected to have had as a result of those medications led to a sudden drop in their blood sugar level. So tremor, dizziness, cool moist skin, hunger, tachycardia, and if it's untreated, progresses to coma and convulsions and death. Interestingly, and I know we're going to hear from our mental health colleagues very shortly, in the olden days, back in the days before the neuroleptic medication, the antipsychotics pre-1950s, one of the ways that diseases or disorders like schizophrenia were treated was that we like to induce fits, and one of the ways that fits were induced is that they were given exorbitantly high doses of insulin to induce an insulin coma, an insulin shock, and we would force patients to have a fit. Now, if they survived, that was always a bonus, but if they didn't, then of course that was completely curative of their schizophrenia. If they survived, often they would have a lift in their depression or an alteration in their mental state after surviving. So fits started to become a considerably a beneficial thing to do for patients. Now, remember, this predates Largactil. 1952, we got Largactil. Is that right? 52, yeah. Alrighty, so we don't use insulin therapeutically to induce fits anymore. You can see that the body can do that well enough on its own. So what are the signs and symptoms? Well, it's important to quickly identify whether your patient is hyper or hypoglycemic. The similarities, of course, are an altered level of consciousness, and if we look at them side by side, the hypo versus the hyperglycemic, you can see that there are a few similarities, but there are a few differences. So a low blood sugar level has an onset in minutes. A patient who experiences hypos, particularly type 1 diabetic patients, will say to you that they can feel it coming. They get the hangries, they get agitated and restless and sweaty and irritable. They have to eat something. Remember that Snickers ad on TV? It's that hangry. Thirst is often absent in a hypoglycemic episode, but in hyperglycemia, because they have such an elevated osmolality of their blood sugar level is so high, their osmoreceptors are firing to their thirst centres, that they're incredibly thirsty. So we see thirst with hyperglycemic, in fact excessive thirst. It's that polydipsia. Respiratory rates are generally normal when we have hypoglycemia. In hyperglycemia, it's typically we're going to see an elevated respiratory rate. Specifically in hyperglycemic emergencies where ketones are being produced. So I can be hyperglycemic with ketones, that's called DKA, diabetic ketoacidosis, or I can be hyperglycemic without ketones. And if I don't have ketones and I'm therefore not acidotic, rarely will I have an elevation in my respiratory rate. There is often a ketotic odour on the breath of somebody in diabetic ketoacidosis. One of the ketones is a volatile called acetone, and we can smell that on the breath. If you haven't smelled acetone before, you've only got to walk into any one of those nail salons. That aroma in the nail salon is that acetone. Blood pressure generally is low in a patient with a hyperglycemic. It may be low or normal or high. Blood pressure is really not an indicator in hypos. A rapid full pulse is often seen in a hypoglycemic event, but in a hyperglycemic event, it is trending towards a shocked state, and it's not unreasonable to see a weak, thready pulse, to have that hypotension and a weak, thready pulse in those patients. Skin is often pale and cooled and clammy in a hypo. In fact, one of the early signs and symptoms of somebody developing a hypo will be those classic skin indicators of shock, pale, cold and clammy. Headache is really, really common in a hypo, or some alteration in sensation in their head is very common in a hypo. So the initial treatment for somebody with a hypoglycemic episode is, of course, to bring up their blood sugar. Our target is to bring up their blood sugar, and how we do that safely will depend on whether the patient has a gag that we can rely on. The patient's awake and alert enough with a hypo, then it would be fair and reasonable to give them something to eat. And the standard management would be a single dose of glucose, and a dose of glucose is 15 grams. So we might look at one of those glucogel tubes. I know that all you ambos carry glucogel tubes. I work in hyperbaric medicine, so we have patients that drop their sugars like a stone inside the chamber. That's a physiology I'd love to unpack for you one day. So we always carry those glucose jelly beans, the really high glucose-rich jelly beans, glucogel jelly beans in the chamber, so that if somebody looks like they're starting to get a little bit sweaty and uncomfortable, we hit them with a 15-gram serve of jelly beans. A tablespoon of honey, or the equivalent in sugar, a tablespoon of sugar is going to be 15 grams. 3 to 5 of those glucogel jelly beans works really well. Now, that's only going to spike that blood sugar level to get them out of the danger period immediately. What we want to do is we now want to load them with another dose of carbohydrate that's more long-acting, that has a longer glycemic index. And this is where a starch should be used. I'm a fan of giving them a slice of bread sandwich, and particularly if it's somebody who frequently has hypos, we know that that can cause problems with down-the-track Wernicke's encephalopathy, just like it does with our patients that have malnourishment or alcoholism. So I'm always going to slap a little bit of Vegemite on that sandwich and give them a Vegemite sandwich just to look after their vitamin B1. I don't know if it does anything. I haven't got a paper on that, but we know that a little bit of vitamin B1 can't hurt, and at worst, it just makes their pee yellow. Yeah? Cup of milk, piece of fruit. If the patient can't tolerate something orally, it's fair and reasonable to give them something parenteral, and glucose or dextrose, same thing, is going to be used. 30 to 50 mils of 50% after we've taken a blood draw to confirm what their blood glucose level is. Alternatively, 10% glucose, glucose 10 in water, and 150 to 250 mils would be a reasonable bolus to bring them up. Remember, that's that 15 to 25 grams we're looking for to get that sugar up. In the absence of having IV access or an inability to have access to intravenous glucose, then glucagon becomes really beneficial. Glucagon in Australia, I can't speak for those that are not in Australia itself, but glucagon in Australia is an over-the-counter rescue medication. In certain states around Australia with different drug legislations, particularly my state of Queensland, nurses in Queensland are authorised to go ahead and give Schedule 3 medications on their own authority without needing an order. So glucagon is certainly something that any nurse in Queensland would be able to administer if need be. Most of you will recognise glucagon as the little orange box sitting in or on or near the crash trolley. What glucagon's going to do, glucagon's a hormone. It comes from endogenously, you create it in your alpha cells of your pancreas, right next door to your beta cells where insulin's produced. And your glucagon is going to go to the liver where you have stored glucose, 2 days worth of glucose, in a big polymer referred to as glycogen. And it just mobilises that glycogen. Remember, your liver has got a 2-day storage of glucose that you can release under the influence of glucagon. So giving glucagon to a patient says to their liver, hey, listen, all those stored Tim Tams, we need you to release those Tim Tams back into the bloodstream. We need you to bring that blood sugar level up. Now, our livers don't start storing glycogen to rescue us from a hypo until we're about 3 to 5 years of age. It fully matures at about 11. Between 8 and 11, we see full maturity of glycogen storage in children. So for that reason, when a child has a hypoglycemic event, it's ideal to give them glucose, not glucagon. Many of you will work in facilities or in organisations that say that you can give glucagon to a child. The manufacturer of glucagon doesn't want you giving it to children under 11. But I understand that you're working in facilities that allow you to go ahead and give glucagon. I would just like you to consider the age of the child before you make that clinical decision. If the liver has not got glycogen because the child's too young to make glycogen, then the glucagon... Really? Oh, I can talk forever. Oh, heck, I can slow down. He just said I've got 20 minutes left. Are you guys into this or are you bored? Excellent. If I'm giving my child some glycogen, I'm expecting they've got a liver that's got... If I'm giving my child some glucagon, I'm expecting that they've got a liver that has glycogen they can mobilise, yes? But if my child is too young to have made enough glycogen for that glucagon that I'm giving them to mobilise, then that glucagon is immediately going to go to fat tissue in that child, that baby, and start the lipolytic process and break down fat. Now, what will that lead to in that child? Ketone production. So if I start breaking down fat, I'm going to start producing ketones. So the danger of giving glucagon to a small child, particularly under the age of 5 or 3, would be that they don't have enough glycogen for the glucagon that you've given them to mobilise to glucose, so they'll start breaking down fat as a surrogate. And for that reason, we have to have concerns about the development of ketones in that child. So ideally, the manufacturer says they don't want the product given underneath an 11-year-old. Some texts will refer to under 13. It's not ideal to give glucagon. I know in our jurisdiction in Queensland where I work, there's certainly protocols to suggest that we can give it down to about the age of 5. I'm nervous giving glucagon to children for all those physiological reasons. Most facilities will have some sort of a hypo kit, an oral hypo kit that has things like juices and sandwiches and biscuits. We certainly have something very similar in our chamber in Brisbane. Anyone that comes in with a blood sugar level, anyone who comes in with a blood sugar level of less than 6 gets something to eat before they go in the chamber. We know their blood sugar levels drop like a stone, and we don't want them having a hypo when they're 14 metres under seawater and it takes us 4 minutes to get them up. Are we happy with hypos? Treatment is easy. Give them some sugar. Okay, let's talk about hyperglycemia. And if we talked about hyperglycemia, we have to have the conversation that we've got two different types of hyperglycemic emergency. We've got those that have high blood sugar levels and they're ketotic. They're making ketones. They are in a state of acidosis because the ketones are acidic. And then there are those that are going to have an increase in blood glucose level, but they're not making ketones. So let's talk about this group over here that are making ketones. I'm going to divide the room again in half. So you are my ketone producing DKA patients, and you are my non-ketone producing HHS patients, hyperosmolar hyperglycemic state patients. We used to call it honk. I wish we still called it honk. It's not called honk anymore. I wish it was honk, because then you would be my honkies. But over here, you DKA people, you cannot go into diabetic ketoacidosis. You cannot make ketones with insulin present. You just can't. And I'll go into that fizz in a minute. You guys over here, you cannot make ketones with insulin present. So now what we've done is we've divided this group of hyperglycemics into two groups. We've got people who can make ketones, which means that there must not have been any insulin present. And we've got a group over here that cannot make ketones, which must mean that there is plenty of insulin present. Does that make sense so far? Good. So tell me what type of diabetes don't have any insulin present? Type 1 diabetes. So this group is represented primarily by our type 1 diabetic population. Now, there's a few exceptions to that. We might have some people that are diabetic because they had a pancreatitis and they had to have destruction or damage to their pancreas. Their pancreas was removed. They could be rendered a surgical diabetic. I think the clever textbooks call that a type 3C diabetic, which is it's just rubbish. Either you're insulin deficit or you're not insulin deficit. So in the insulin deficit group, because you don't have an adequate amount of insulin, you can make ketones. But over here, this group are insulin-resistant diabetics. And I'm not just talking about type 2. I'm talking about PCOS. I'm talking about obesity. I'm talking about metabolic syndrome and syndrome X and anything that's going to trend towards an overproduction of insulin. You have insulin levels that are higher than most. And because your insulin levels are higher, you cannot make ketones. Because your insulin levels are absent or lower, you can make ketones. And so we have to ask the physiological question as to, well, why does insulin play a role? Because I thought hyperglycemia was about glucose, and here you are, Rob, talking about insulin. And we've got to come back to the very basics and understand what our physiology and what our hormones actually are doing for us. Insulin is not a hormone that manipulates your sugar like you were taught. Insulin is classified in our biology as a growth hormone. It's a growth hormone for fat. Insulin is your fat growth hormone. So when you have an abundance of fat growth hormone, are you melting fat or are you growing fat? You're growing fat. You're not melting fat. And if you have a deficit in fat growth hormone, are you melting fat or are you growing fat? It's a fat growth hormone. If you've got a deficit in fat growth hormone, are you finding it easy to strip fat? Yes, you are. And it's for this very reason that when we look morphologically at our populations of diabetes, anyone who has a diabetes syndrome that resembles a type 1 picture and insulin deficit syndrome, they're leaner than those that have a type 2 diabetic syndrome. Now, everything exists on a bell curve in science, and so I'm speaking to the middle of the bell curve, not the outliers that are 1 or 2 standard deviations left or right of the mean. But let me just make the bold statement. there is no skinny type 2s and there's no fat type 1s. And it's nothing to do with sugar, it's everything to do with insulin. If you're abundant in fat growth hormone, you're growing fatter. And you have great difficulty, even with hyperglycemia, because you've got large amounts of insulin, in stopping your fat cells from releasing those triglycerides into the blood to be then turned into ketones by the liver. So here's what happens. My cells are starving. My insulin's either not working, meaning my cells are starving. Glucose isn't being transported through the glucose transporter molecule GLUT4 into my cell membrane. My cells are starving, they are hungry, glucose stays out in the bloodstream, my insulin's not working. Insulin-resistant syndromes, yes? Or my insulin is absent, I don't have enough insulin, meaning I'm not able to transport that glucose through my GLUT4 transporter into my cells to feed my cells. Either way, my cells are starving. And as my cells are starving, yet my blood sugar level continues to rise. Hyperglycemia in both groups, yes? So I have blood glucose levels that are rising. Now, because I'm now insulin abundant, my cells are starving, what I'm going to see is an increasing rise of blood glucose because that glucose isn't moving in, but our type 1 diabetic population who have a deficit in insulin, their fat cells now are going to start releasing triglycerides. Those triglycerides are going to be transported to the liver, where now they undergo a process called gluconeogenesis, the new creation of glucose. What happens to their blood sugar level is they convert their fat into glucose. Their blood glucose level continues to rise. Now they're vomiting and vomiting and vomiting and vomiting, yet their blood sugar level's still going up and up. Can you see their liver is converting the glycerol from their triglycerides into into sugar? Now what's happening to the fatty acids that are part of that triglyceride molecule is those fatty acids are undergoing a beta oxidation and they're being turned into the ketones, which are acidic. Do you see it's my type 1 diabetics, therefore, who are insulin deficit that are able to release fat and therefore that fat's being converted into ketones. They are hyperglycemic, there is your hyperosmotic emergency, but they're producing ketones and now they're becoming acidotic. Does this make sense? An insulin deficit trends towards the creation or the production of ketones from the melting or the breakdown of fat. Now, for you guys over here that can't make ketones, because your insulin's so high, insulin actually blocks the process of fat cells releasing those triglycerides. So as my insulin levels rise, that blocks or impairs my hormone-sensitive lipase, an enzyme on my fat cells that asks the fat cells to release the triglycerides. Let the triglycerides go. So you can't let your triglycerides go because insulin is blocking that enzyme, the HSL, the hormone-sensitive lipase molecule, from allowing that triglycerides to be released. So if I'm not releasing triglycerides from my fat because my insulin levels are too high, then my liver is not receiving those triglycerides to convert them into ketones. Yes? Good. Well, that was easy. Just 5 minutes to go. So diabetic ketoacidosis and HHS ultimately are treated in a very, very similar pathway. Have you heard the expression, the solution to pollution is dilution? So we fluid resuscitate these patients. We load them with fluids. Absolutely, I want to bring somebody's blood sugar level down. Absolutely, I do. Because in elevated blood sugar levels, I am hyperosmotic. My milliosmoles are through the roof, and what I want to do is I want to bring my osmolality back down at least to close to top end of normal. Under 300 is a good target point, but around that 290 is what we're looking for to try and bring their milliosmoles down to. We need to slowly dilute that blood glucose down. That's the same as, when they make you a drink out there and it's a little bit too strong. You put a bit of water in it to dilute it down so it's more palatable. Have you tried the lemon iced tea? It's just a little bit...
You like lemon?
I do, but I prefer the vodka that you gave me last time we were in Thailand. So, what we're going to do with we've just done this, the breakdown, the creation of ketones, we've done that. I've put myself a little bit ahead. I forgot that I actually had these slides. My bad. So what we want to aim to do is we want to aim to dilute our patient. So with nausea and vomiting and abdominal pain, generalised weakness, all of that right down to where it starts to say dysuria and polyuria, all of that looks like it could be a hypo, but for the fact that they have an elevated blood glucose level. On examination, somebody with hyperglycemic events are starting to trend towards a state of dehydration. Remember, with very, very high blood sugar levels, their kidneys are driving very, very hard to try and get rid of not only glucose, but get rid of a lot of water. Where's the water coming from in a patient that's hyperglycemic? Where are they being dehydrated? Are they hypovolemic? Or are they being dehydrated from their tissues? It's coming from their tissues, isn't it? If I've got very, very sugary blood right next to tissue, it's going to be dragging water out of the tissue in an attempt to try and correct the osmolality, that oncotic pressure, that osmotic pressure. Yeah? So they're dragging water out of their tissues. Of course, that's going to cause them to have a transient hypervolemia. The kidneys don't like you to have too much water floating around in your bloodstream, and it will start to strip that. So not only are they losing that water and losing that glucose at the same time, it's an attempt to try and correct the osmolality. We're going to test for serum ketones, and elevated ketones is your absolute turning point diagnostic criteria for a patient having a DKA versus an HHS. They are often in a state of acidosis, and of course that acidosis is ketone, so it's a metabolic acidosis, so we're checking their pH, and this is where blood gases that are venous blood gases really come into their own. Venous blood gases don't offer a lot other than being able to tell us accurately what somebody's pH is doing. We want to have a look at things like serum sodium. We definitely want to be looking at serum potassium. One of the big concerns about correcting blood glucose levels that are elevated is that we will often use insulin to correct their blood glucose level. Not just are we diluting them by providing fluid resuscitation, which alters their electrolytes, but when we start to give these patients insulin, not only is glucose transported into the cell, but also potassium is transported to the cell, reducing their overall serum potassium levels. So what is the emergency if glucose never killed anyone quickly? Well, the emergency is volume depletion. The emergency is profound dehydration, and in the ketoacidotic patient, it's in addition to that, it's going to be the acidosis. So the priority management is always going to be, in both classes, it's going to be fluids, keeping a close eye on potassium as we're giving fluids, and then introducing insulin very quickly into that patient once we've corrected their potassium. Normal saline or Hartmann's initially is going to be our initial fluid. There are different jurisdictions, 5 minutes, thank you. There are different jurisdictions around the country that are going to have slightly different protocols, but almost certainly normal saline is where it's going to start. And usually after about 1 or 2 litres of normal saline as a fluid resuscitation fluid, we will shift across to lactated ringers or a Hartmann's solution. We must not be giving insulin to a patient that has a potassium of less than 3. So we've absolutely got to be considering giving fluids that have been fortified with potassium. Otherwise, we can force that patient, as we're trying to bring down their blood sugar level, we can force that patient into a state of hypokalemia. Again, another incident report that we don't want to be having to deal with. In a hyperosmotic state, HHS, formerly called HONK, the mortality is much higher. We tend to recognise DKA very quickly because we test for ketones. But the management of somebody who is generally older with type 2 diabetes with HHS, generally a lot older when they develop an HHS, is often fraught with the complication of, in an older person, fluid resuscitation can be a little bit problematic, particularly if that older person is starting to, with advanced diabetes over many years, have started to develop some heart failure. Giving fluid resuscitation aggressively to somebody in heart failure, therefore, is asking for them to third space into their lungs and pulmonary edema and other complications that can ensue. The condition is characterised by extreme hyperglycemia. A patient with diabetic ketoacidosis, our type 1 patients who go into DKA every time they get a fever, often will have blood sugar levels that are mildly elevated, 14, 17, 22, arguably hyperglycemic, but also arguably not 50 and 55 and 60, not huge blood sugar levels, but in our type 2 diabetes hyperglycemic emergencies, our HHS patients traditionally will have blood sugar levels that are right up in the 30s, 40s and 50s. These patients are so profoundly osmotic that they've got extremely high blood glucose levels. They have a much higher mortality, somewhere around that 10 to 15% is the mortality level for these patients. The hyperosmolality comes literally from the glucose. Make the blood more sugary and your blood's going to now start to drag water out of your tissues, driving that diuresis. They are profoundly dehydrated and they don't make ketones. Remember, with an elevated insulin level, they can't make a ketones. Ketones aren't produced in the presence of high levels of insulin, and traditionally your type 2 diabetic is insulin abundant, not insulin deficit. There are some exceptions, and that would be your patient who has a medication that deliberately forces a diuresis of glucose. So newer medications like our empagliflozin and the gliflozin family, the SGLT2 inhibitor medications, they can certainly lead to a form of ketoacidosis in type 2s, but quite rare. This is a before and after picture of what your cells look like before your HHS and what your cells look like after your HHS. I've always said that a picture tells 1,000 words, despite the fact that I use more than 1,000 words. The point here is what we want to take as these sultanas and turn them back into grapes. So we're not just fluid resuscitating our patient to try and get their trivial 5.5 litres of vascular fluid back to 5.5 litres. They're often not hypovolemic in terms of their vascular space, but they are hypovolemic when we talk about their interstitium and also into their intracellular water load. Can you see that they are profoundly dehydrated, and they often will take litres and litres and litres to replenish their cells back to normal. Cell membranes are generally freely permeable to water. The osmolality, therefore, in the blood is going to drag water from them. We're going to be measuring milliosmoles in patients that have extreme hyperglycemia, particularly those with HHS. And our osmolality sits at around that 290 is considered to be normal. Anything up above 300, we know that patient is quite hyperosmotic. So what's the crisis here? Is it the high blood sugar level or is it the dehydration? It's the dehydration. That's the crisis. Extreme hyperglycemia, far more so than diabetic ketoacidosis in our HHS population. The expected treatment, of course, is going to be fluid resuscitation, and we're going to fluid resuscitate these patients like we would with a sepsis patient. It's aggressive fluid resuscitation, that 20 mils to 30 mils per kilo as an initial fluid bolus over the first hour is considered to be absolute standard management for these patients, keeping a very close eye on listening to, on watching their respiratory parameters while we're fluid resuscitating. There shouldn't be a clinician in this room that's comfortable starting aggressive IV fluids on any patient, not just this population, but any patient without first listening to the chest. And if you've ever found yourself working in a clinical space where you've had to put IV fluids onto a patient any faster than 6th hourly and you haven't first listened to their chest, I would suggest take that stethoscope from around your neck. It's not a piece of jewellery, and actually use it on your patient. Please assess respiratory parameters with your stethoscope before you start aggressively fluid resuscitating patient. That will become your friend later in the shift when your patient's now got rattles and rails and crackles and creps, the sound it makes when your lungs get wet. That's another conga line tonight. Rattles and rails and crackles and creps, the sound it makes when your lungs are... Rightio. Very good. I want to hear that back. Okay. So insulin. Do I give insulin to these hyperglycemic patients? We've had a whole conversation around watering the plants, but not giving insulin. Well, it should stand to reason that if the lack of insulin is the thing that's causing them to become ketotic, then the giving of the insulin to the patient with type 1 diabetes and the giving of insulin to a patient who is in ketoacidosis, it makes absolute sense that insulin is designed to shut down ketosis. It's the lack of insulin that's causing them to make the ketones. So give them insulin to stop them making the ketones. And you know the side effect of insulin? Their blood sugar level might come down as well. That's a benefit. But to this population over here that are already insulin abundant, giving them insulin just tops up their insulin resistance and allows them now to control blood sugar level. So your blood sugar level is coming down as a type 2 with HHS. Your blood sugar level is coming down predominantly from the aggressive fluid resuscitation, but then we're adding insulin as a bonus to bring your sugar levels down. The more sugary your blood, the more osmotic you're going to be. So we need to bring your blood sugar levels down by sending that sugar to bed inside cells. Over here, your type 1 diabetes population with DKA, we're wanting to, number one, stop your ketosis. I'm not that worried about your blood sugar level at 13.6. It's not 50 like these guys. This is a blood sugar level that's not worrisome. The worry here is your acidosis. It's your ketones. So I need to block those ketones. I need to stop that continuing production. So stopping that ketosis becomes our focus in the patient with DKA. Can you see that whilst insulin levels are both going to manage glucose levels, it's important that we recognise that there's two reasons why we're giving insulin in these two different syndromes. And that's the slide that you've all been waiting for. So, are we sweet?
Perfect. Thank you so much, Rob. Let's take 5 minutes, and then Molly's going to be up here for our final photo of the day.